الله الرحمن الرحيم. كل سنة وحضراتكم طيبين، وكل 100 سنة وانتم طيبين وأهل المنصورة بخير. يسعدنا الأستاذة الدكتورة نهال الشقنقيري هتكلمنا النهارده عن very important presentation, which is the challenges in pediatric cataract surgery. Pediatric cataract surgery هي السهل الممتنع، ولكن لها أصول. والدكتورة نهال هي من أقدر الناس. أنا زرت جامعة اسكندرية وشفت الوحدة اللي هي بتديرها للأطفال، حاجة يعني أرقام رهيبة من الفحوصات ومن العمليات. الدكتورة نهال الحقيقة بتقول فيها، وأنا يعني أي حد بيدرس في البيدياتريك اوفثالمولوجي ان جنرال أنا أنصحه يقول الدكتورة نهال وهيشوف حاجة مش متوقعة كمان. اتفضلي يا دكتورة نهال.
I'm going to speak about challenges. My talk was about challenges in pediatric cataract surgery. I actually choose one challenge in pediatric cataract surgery is how to manage the posterior capsule. In the conventional surgery or easy surgery in pediatric cataract, when dealing with an infant below 2 years of age or below 1 year of age, where we go for cataract surgery for these infants and then fit the babies immediately with spectacles without IOL implantation. The easy surgery or the straightforward surgery starts as such, going with 2-port incision, corneal incision using MVR knife 20 gauge, and then doing anterior capsulorhexis 5 or more than 5 6 millimeter rhexis, and then proceeding with the posterior capsulorhexis by tearing the posterior capsule and injecting here into the burger space, the along between the posterior capsule and anterior vitreous space, and then proceeding with a 25 or 23 gauge rhexis forceps, because you have to use very fine instrumentation, and proceeding with a posterior rhexis. You start by a small one, and then you can enlarge it in a spiral way in order to have both of them. The anterior and posterior rhexis should be 5 to 6 millimeters. We go for anterior vitrectomy, and finally we close the wound. However, it's not always like that. And if we intend to implant intraocular lens in these infants, we plan now for a perfectly central, and it should be 5 millimeter rhexis and not more. And then how to go for the posterior rhexis if you have a very clear or transparent posterior capsule like that, by what is called hooking. We hook the posterior capsule, and then we make it like a tent. It is called tenting. And then tearing of the posterior capsule. And in order to be perfect, it has to be a triangular tear like that. And then we proceed injection again into the burger space, and it should be rounded halo, circular halo like that. And it should not be whirly, otherwise it means that you did penetrate the crevice into the anterior vitreous space. And then we proceed with the posterior rhexis in the usual manner. And in this case, the posterior rhexis should be 4 millimeter in size. And then anterior vitrectomy, and in the back implantation using a folder or using an injector of a single piece or a multi-piece Acrysoft IOL between the anterior and posterior rhexis. But as I told you, these are the straightforward cases. Sometimes we may face problems dealing with the posterior capsule. This is how to manage the posterior capsule in simple cases. Sometimes we are faced with posterior polar cataract and posterior capsular plates. If you see here, after irrigation aspiration, there are different posterior capsular pathologies. Posterior capsular plates of variable pathology, large, fibrotic, calcified, posterior lenticonus that may be eccentric or central like that, or diffuse opacification of the posterior capsule in a pearly matter or a fibrotic matter. How can we deal in each case? If we have a posterior capsular plate like that in the posterior capsule, we may use the conventional rhexis and proceed with posterior rhexis away from the plate around it. and then leave the plate in place because it is usually adherent to the anterior vitreous space. We don't get it outside the eye, and then proceed with the vitrectomy in the usual way. And now it is a simple case of pediatric cataract. Sometimes these opacities actually are not related to the posterior capsule. They are related to the anterior vitreous space. So we can perform posterior rexes and then proceed with clearing of the vitreous with the cutter, and now it's a simple case. Another case, can you see this large opacity? It is not actually in the posterior capsule, and it is very easy to perform the posterior rexes and then proceed with the anterior vitreous. You should specify where is the pathology. And if you look at this photo, there are here, this is the anterior rexes, posterior rexes, and the edge of the plate. And here it is a simple surgery at the conclusion of surgery. If we tend to implant intraocular lens in these eyes with plates, either after performing posterior rexes here around the plate, the posterior rexes, and performing vitrectomy, we may implant inside the capsular bag between the anterior and posterior rexes. However, sometimes when we perform posterior rexes around these plates, the posterior rexes becomes large. We should not panic. Still, we can implant Ecrisoft into the sulcus and then push the IOL optic behind the anterior rexes. We perform what is called optic capture technique, and this is how it appears after surgery. The IOL is implanted, the haptics are in the sulcus, and the optic actually is pushed behind the anterior rexes, but it has all advantages of capsular IOL as if you did implant inside the capsular bag. What if you have a large plates like that? Either you go for peeling first of the plate, we peel it first with cystitome, and then perform posterior rexes in the usual manner. This is another eye. We peel it off with a cystitome and then perform the rexes in the usual way. Or if it is large like that and calcified and protruding into the lenticular space like that, and you cannot peel it off the posterior capsule, now we should use a 23 gauge, this is the retinal scissors, and we cut around the plate, this fibrotic plate, and perform the vitrectomy, and now again it's a central surgery. Or we may use peeling, combined peeling and cutting. You peel off first the capsular plate, peel it off, the posterior capsule, and now a smaller plate can be cut around, and now we have a simple anterior and posterior rexes. What if we have diffuse opacification of the posterior capsule? It may be mild, it may be moderate, it may be severe pearly or severe fibrotic. For mild cases, we can perform posterior rexes by rexus forceps easily. But for moderate cases of opacification, we should use either a scissors or sometimes we may use a cutter, and now it's a simple surgery again. However, diffuse of the posterior capsule, if it is pearly, it is very easy to perform posterior rexes with the rexus forceps because it is usually soft. However, fibrotic, we have to use the scissors in order to perform a rounded opening, and here before and after surgery. Yes, you have extensive fibrosis, but you have a clear visual axis. Donut-like cataract. The donut-like cataract is actually, it's a very tough cataract, and there is adhesion or fusion of the anterior and posterior capsules in the center of the lens. This is how it appears. During surgery, when we start the anterior rexes, this is the only type of anterior rexes in children where we pull towards the periphery. We always say pull towards the center in order to avoid tearing toward the center. After performing a wide anterior rexes, aspiration of the donut-like cortex, and then now it's a simple case. Here, this is the calcified anterior and posterior capsule together. We perform by cutting around the fibrotic plate, this fibrotic plate, and here at conclusion of surgery, and here immediately after surgery with clear visual access. Posterior lenticonus. Posterior lenticonus actually presents as a posterior polar cataract related to the posterior pole of the lens, with posterior excavation, localized excavation of the posterior capsule, with a fibrotic edge and a pigmented base. Here how it appears against red reflex. During surgery, after performing anterior capsular access, we don't go for hydrodissection or hydrodelineation in order to avoid bursting and rupturing of this cup. And we go after irrigation aspiration, which is done very meticulously and carefully. We may perform the posterior rexus away from the cup, around the cup, circumferentially. And then, with a cutter, we can cut and aspirate and eat up the cup. And now it's a simple case, and we perform vitrectomy, and we can implant inside the capsular bag between the anterior and posterior rexes. And here, how it appears after surgery between the anterior rexes, as if it's a simple surgery. Sometimes the lenticonus is eccentric and fibrotic. So how can we proceed? This part is done by rexus forceps, and this part done by scissors. And here, how it appears at the conclusion of surgery. Congenital posterior capsule defect. You have to spare some time looking at the cataract before surgery in order to know what to do. Here, if you look this line, this actually gives us that there is a sort of a defect here in the posterior capsule. Here, after performing anterior rexus, and this is the edge of the posterior capsule defect. Again, we don't go for hydrodissection or hydrodelineation, and we be so careful during irrigation aspiration. And this defect actually here appears after irrigation aspiration. It is enlarged with the rexus forceps, and the anterior vitreous opacities are cleared by vitrectomy. And here, at conclusion of surgery, it appears as a simple pediatric cataract surgery. When to suspect? Look here, it is actually a deeply seated opacity, a rounded, well-circumscribed, deeply seated opacity. If you look to this infant, this is a total cataract, and actually it lies immediately behind the iris. This is a total cataract immediately behind the iris. But if you look to that one, it is a deeply seated opacity. It appears as if it is very posterior. So you should suspect. Together with another sign, it is called a ring sign. If you look here, there is a ring here delineating a posterior capsule defect. This is the start of anterior rexus, and here, this is the defect. Another baby with posteriorly located opacity. This is the ring sign, which delineates a large defect. Usually, this well-circumscribed opacity, where very well-circumscribed opacity, hides behind a defect, and it is usually and clogs the defect. This opacity clogs the same size of the defect. During surgery, as we said, after anterior rexus, we don't go for hydrodissection and hydrodelineation also in these cases, and we use either dry aspiration or very minimal irrigation. And here is the defect. It is enlarged in order to around it to perform posterior rexus in the usual way and anterior vitrectomy. Actually, there are many shapes of the congenital posterior capsule defect. It may be large, like that. It may be small. It may be elliptical in shape, and here you should suspect. Here it shows that there is something elliptical. It revealed an elliptical defect. It may be elliptical, it may be rounded. The posterior capsule around it may be transparent. It may be central or maybe eccentric, as we said. The posterior capsule may be transparent, but sometimes after aspiration you find that the posterior capsule is opacified, and these opacifications actually are related to the back surface of the posterior capsule. If we intend to implant intraocular lens in these cases, after irrigation aspiration, we should change this defect into a rounded rhexis. So we can use a posterior rhexis to perform a rounded rhexis, and we may implant inside the capsular bag here the acrosoft between the anterior and posterior rhexis. However, in cases like that with a large defect, we cannot implant inside the capsular bag, so we eat up the whole posterior capsule by a cutter and then implant acrosoft in sulcus and perform optic capture technique. Posterior capsule defect may be associated with another pathology, which is PHPV. If you look, this is a defect in posterior capsule, and this is a vitreous cyst actually protruding into the vitreous, and this is a posterior polar cataract due to persistent hypoplastic primary vitreous. In these cases also, no hybrid-section, hybrid delineation, and after aspiration and anterior, we clear the vitreous from this opacity first, and then we have to remove the whole posterior capsule because it is all pathological in this case. And after removal of the posterior capsule, we may polish the back surface of the anterior capsule to remove all the lens epithelial cells, and then again implant in sulcus and push the optic and perform the optic capture technique. And the last thing, أنا أسفة إن أنا أطلت على حضراتكم. The last thing is iatrogenic tear in the posterior capsule. You are doing irrigation aspiration, and actually you tear the posterior capsule before performing posterior rhexis. As in this case of posterior polar cataract, during irrigation aspiration, if you don't have a pediatric anesthetologist who is perfect and there is a high vitreous pressure, you may tear the posterior capsule like that, especially in the weak points near a posterior capsular plate. Here, after you did go out, the tear increases in size, meaning that there is a high vitreous pressure, more and more size. In these cases, you have first to perform localized anterior vitrectomy and then make the tear in a rounded fashion using a scissors and then a rhexis forceps. And then after finishing posterior rhexis, it came to be large like that. You cannot implant inside the capsular bag. Again, implant in the sulcus with optic capture technique. So, finally to conclude, in pediatric cataract surgery, it is not always straightforward, and you may face many pathologies in the posterior capsule, and it is not always possible to implant inside the capsular bag between the anterior and posterior capsule. However, even if you implant inside the sulcus, and you have a perfectly rounded anterior rhexis, you may perform optic capture technique, which has all the advantages of capsular IOL, good fixation and good centration. And this is a few months after surgery and 2 years after surgery with a clear visual axis and a good centration. And thank you very much for your kind attention.
في أي سؤال للدكتورة؟ اتفضل يا دكتور حمودة ليه.
وطبعا عرض جميل جدا ربنا يكرمك يا دكتور. انا بس هتكلم من البوستيريور سيجمنت بوينت اوف فيو. يا عم بالراحه عليا يا حبيبي. حاجات معينه احنا بنلاحظها احنا في الريتنا دايما بنبص نفسنا ان احنا متشابهين جدا، احنا بنبص دايما للكوميونيكيشن، يعني ما بنبصش لحاجات سيل فورد شبه الكوميونيكيشن. لكن انا شايف ان البوستيريور ريكسس كلها ممكن تستغني عنها وأضامن. طبعا حضرتك بيرفكت سيرجن، انا بتكلم عن الناس اللي هيبداوا الشغل معاهم. ممكن تضمني تحط في الباك تماما، تحط في الباك وتعملي بارت سكاننج او بارت بليكاتا وتصير كابسولوتومي انتيفيتريكتومي ان ذا سبوت. فبالتالي لا عايز ريكسس ولا عايز احط لينز فين وهتقع وهتبقى كابشر. ممكن اضمن ان انا احط اللينز في الباك 100% لو عملت انتيرو عادي خالص، وبحط اللينز واعمل بارت بليكاتا اخش اشتغل. وخاصه ان الفيتريكتومي دلوقتي موجود في كل حته وتشتغل في السمول 23 او 25، فدي تمنع حاجه جامده جدا بالنسبه للناس المبتدئين. يعني انا بعتبر اخواننا اللي بيشتغلوا ريكسس في القسم عندنا بقول لهم دي للناس البيرفكت سيرجري زي حضرتك، لكن مش الناس اللي هيبداوا، لان لو ناس بدات بيها يبقى انا ضامن انها هتشتغل كتير جدا بوستيرو لينز كابشر ولينز واقعه ورا هتشتغل. فالاحسن حط في الباك واعمل بوستيرو برضه في الباك. دي نقطه. النقطه الثانيه لو لاحظت احنا بنشتغل يعني كاريتنا برضه من حوالي 20 سنه، ان البيدياتريك كاتراكت كلهم بفرق بين حاجتين، بيدياتريك كاتراكت اقل من سنتين وما فوق سنتين اللي هو الايدج اوف البروبر لينز بلانتيشن. انا عارف انك تحط لينز بدري قوي، بس انا دايما بقول لاخواننا برضه ما تحطش لينز بدري. وحضرتك حاطه صور جميله جدا لنظارات لاطفال صغيرين، ممكن طفل يلبس نظاره وعنده شعر. فلا يقول لي بالنسبه لنا كاريتنا ما تحطش اقل قبل سنتين خالص. والاحسن ستيج احنا جربناها وبنعملها لغايه دلوقتي في خاصه في وجود الفيتريكتومي ان احنا بنعمل بارز بلانا لينزكتومي من غير ما افتح انتي شابر خالص، غير ان افتح حاجه دخل فلويد واشيل كل اللينز وبالكبسول نفسي اقطعها قطعه مدوره جدا بالبروب انتيرو وبوستيرو، وبعد 3 شهور الى 6 شهور بتبقى الانتيرو كبسول دي عباره عن حته حجر خالص فيري فايبرز. فقوم جاي حاطط اللينز، زمان كنا بنحط بي ان ايه، دلوقتي بنحط 2 من 10 نحط الفولدر لينز. فدي بديل ممتاز جدا، يا ريت كنا في البيدياتريك سيرجري تبص عليه.
بسم الله الرحمن الرحيم. بالنسبة لنا I go for a pediatric cataract surgery and then I go for a post-plicata approach. I think it needs somebody very skilled, not me. لأن the eye is extremely soft. During pediatric cataract surgery, extremely soft and it collapses over itself. If I go and implant another, maybe I've done 6,000 cases, 7,000, بس كل حالة as if I'm performing it for the first time. الeye بتبقى soft جدا خصوصا if I implanting before 1 year of age. دي أنا I've been told go for challenges. إنما if you know حضرتك the principle of a simple pediatric cataract surgery, it is very easy to perform and very easy to go for a posterior rexus. Pediatric cataract surgery is not for anybody to go for. He has to be subspecialized in pediatric cataract surgery. Concerning a post-plicata approach, why I go behind the limbus if I can go simply through the cornea with a very straightforward surgery.
بس ده الكونسيبت اللي بيوصله، ان الخوف من البارز بليكاتا ما عادش خوف. بارز بليكاتا على الليمبس جاست بوستيرولي، مش هتقطعي الريتنا زي ما كنا خايفين زمان، مش هتقطعي الريتنا، مش هتعملي مشاكل. البروبس كمان الجديده 23 او 25 بقت حضرتك في الاعتبار، هتلاقيها اسهل بكتير. الانتيرو سيجمنت فيري ستيبل، مش فاتحه فتحه بسيطه هتفرق خالص في الرياكشن في البوست.